Девочка не вернулась.
А что-то их не видно никого.
А вы скажите, чтобы не отметилось.
Можно начинать, So, good day, my dear colleagues. We'll start the lecture. We made it later than it had to be, but it is not dependent on me, believe me, please. So, we will tell about abnormalities of the fertilized ovum. We will tell about polyhydramnios, oligohydramnios, multiple gestation. So, first of all, we will try to memorize a few words about amniotic fluids itself and what is the function and medical importance of the amniotic fluid. Amniotic fluid is a liquid that surrounds the fetus after the first few weeks of gestation. Amniotic fluid is a clear, slightly yellowish liquid present in the amniotic sac, which is very critical to the fetal growth and development. It supports its growth and development during all the pregnancy. During much of pregnancies, amniotic fluid is derived entirely from the fetus and has a number of functions that are essential for normal growth and development. What are these functions? It helps to protect the fetus from trauma to the maternal abdomen by cushioning sudden blows or movements. It cushions the umbilical cord from compression between the fetus and uterus. It helps the developing fetus to move in the amniotic sac, which allows for proper bone growth and muscle development. It helps the lung to develop properly. Keep a relatively constant temperature on the fetus, protecting from heat loss. It has antibacterial properties that provide some protection from infection. It serves as a reservoir of fluid and nutrients for the fetus. How it is formed? As about formation of the amniotic fluid, in the first half of pregnancy, amniotic fluid is derived from the fetal and maternal components. In early gestation, the coelomic fluid with the coelomic cavity stays in direct contact with the mesenchyme of the developing placenta really during the first pregnancy. This special fluid-filled space starts from forming and about the 5th day after fertilization. Before it disappears, the coelomic cavity acts as a transfer area as well as reservoir of the nutrients for the growing embryo. The coelomic fluid has shown to have infiltrated maternal serum as well as the products derived from the secondary yolk sac and later placenta. This fluid in early gestation is a dairy seed that is identical to the fetal and maternal plasma but with a lower protein concentration. The fetal kidneys begin to function about week 16. Fetal urine also contributes to the fluid. During late gestation, the second and especially the third trimester, fetal urine becomes the largest source of the amniotic fluid. Lung secretion, gastrointestinal secretion, excretion from the umbilical cord and placenta surface contribute to the composition of amniotic fluid as well. However, lung secretion alone make up as much as 1/3 amniotic fluid. By term, a fetus produces an average from 500 mg to 700 mg daily, with a slight decline in our fetal urine production after 40th week gestation. Normal amniotic fluid volume varies. Based on numerous studies, it has been determined that amniotic fluid volume increases steadily throughout pregnancy to a maximum of 400 degrees or 1,200 degrees of milliliters at 34-38 weeks. However, wide variation does exist. Pathophysiology of amniotic fluid is of great importance because it can show us what are the problems disturbing the fetus. The volume of amniotic fluid reflects the balance between fluid production and movement of fluid out of the amniotic sac. The regulation of this process is incompletely understood. In late gestation, the primary source of amniotic fluid production are fetal urination and secretion of lung fluid, as we already told. Oral or nasal secretion make minimal contributions, but it takes place too. The main routes of amniotic fluid removal are fetal swallowing and absorption via the intramembranous pathways. Even a relative minor increase in daily fetal urine production or decrease in fetal swallowing can result in a marked increase in amniotic fluid volume. So here is shown amniotic fluid regulation, physiology of amniotic fluid regulation, as we already discussed. What is the clinical significance of amniotic fluid? Amniotic fluid is a highly complex and dynamic system that is an important parameter of assess fetal well-growing, fetal well-being, and development. Fluid volume abnormalities can directly interfere with fetal development, causing structural abnormalities such as pulmonary hyperplasia, some other, and mostly they are dependent on maternal disorders. Abnormal amount or appearance of the fluid may also be an indirect sign of an underlying disorder such as fetal hypoxia, neural tube defects, or gastrointestinal obstruction. Inadequate volume of amniotic fluid is associated with a number of obstetric complications and can lead to the fetal seizure. Sonographic evaluation of the amniotic fluid can thus aid in the diagnosis of fetal structural abnormalities and fetal compromise and can help in making pregnancy management decisions. The volume of amniotic fluid is absolutely associated with the development of the fetus. It is absolutely associated with the condition of the fetus and its health. Abnormal amniotic fluid volume may suggest fetal congenital anomalies such as gastrointestinal or urinary tract obstruction, renal abnormality, chromosomal abnormalities, trisomy 18 for example, and fetal growth restriction. Abnormal amniotic fluid volume has been associated with an increased risk of a variety of adverse perinatal outcomes. An abnormally high level of amniotic fluid known as polyhydramnios alerts the clinician to possible fetal anomalies. Inadequate volume of amniotic fluid, also known as oligohydramnios, results in poor development of the lung tissue and can lead to fetal abnormalities and even death. In this case, we have to know how to calculate amniotic fluid volume, how to understand. And in our practical class, most of you have some problems with methods of calculation of amniotic fluid. Thus, we will discuss slightly shortly such methods. Single deepest pocket measurement, the easiest, the most routine. It is done with the help of ultrasound device. For this type of measurement, the uterus is divided into 4 quadrants. The amniotic fluid volume is measured vertically in the deepest amniotic fluid pocket. Values below 2 cm indicate oligohydramnios. Values over 8 cm indicate polyhydramnios. Please remember, if it is single deepest pocket measurement, the normal range more than 2, less than 8 centimeters amniotic fluid volume. The advantage of this method is simplicity, making it the most commonly used method in practice. It is also the method of choice in multiple gestation. In cases with multiple gestation, a range of 3 to 8 centimeters is defined as normal. With this method, polyhydramnios is classified as mild, moderate, or severe. Mild polyhydramnios is classified by a value 8 to 11 centimeters, moderate classified as a value between 12 to 15 centimeters, and severe above 16 centimeters up to 86. Calculation of the amniotic fluid volume with the method known as 4-quadrant method, and it is known as amniotic fluid index. It is more accurate, comprehensive with amniotic fluid volume calculated with the single deepest pocket volume. The amniotic fluid index is an estimate of the amniotic fluid volume in the fetus, and it is part of the fetal biophysical profile. Of course, it needs special device. Calculation of amniotic fluid index. Here is shown that uterus as well as maternal abdomen is divided in two imaginary quadrants with linea nigra and umbilicus acting as the vertical and horizontal axes respectively. The deepest pocket divide of umbilical cord and fetal parts is measured in vertical dimension. It means that the deepest pocket at any quadrant would be measured just with condition when there are any other parts of the fetus, umbilical cord and uterine wall. Measurement of the four pockets is done in centimeters. Sum of all of these four quadrants measurements is meaning amniotic fluid index. Normal amniotic fluid index value range from 5 to 25 centimeters. So let me repeat again. Single deepest pocket measurement number from 2 to 8 centimeters. Amniotic fluid index means measurement in four quadrants. Normal range is from 5 to 25 centimeters. And here is shown how it is done in ultrasound. Again, calculation. Abdomen is divided into four quadrants: upper right, upper left, lower right, lower left. Measure of the deepest volume at any of these quadrants. Then summary had to be done. Amniotic fluid index, which is less than 5 to 6 centimeters, is considered as oligohydramnios. Amniotic fluid index, which is more than 20 to 24 centimeters, is considered as polyhydramnios. The normal range for amniotic fluid volumes varies from gestational age. As a rule of thumb, less than 8 implies oligohydramnios, more than 25 implies polyhydramnios. Amniotic fluid index between 8 to 18 is considered normal. So you had to remember that there is special table. Special table is dependent on the term gestational age, because any gestational age may have its normal range of amniotic fluid. And single deepest pocket, also called the maximum vertical pocket or the largest vertical pocket, the deepest vertical pocket, is the vertical dimension in centimeters of the largest pocket of an amniotic fluid, not persistently containing umbilical cord or fetal parts, and measured at the right angle to the uterine contour. The horizontal component of the vertical dimension must be at least 1 centimeter. The usually accepted values are less than 2 centimeters in the case of oligohydramnios, 2 to 8 normal, more than 8 indicates polyhydramnios. Here is shown single deepest pocket. Two diameter pocket technique is known also, used also in practice. Try to remember this term, two diameter pocket technique, TDP, but it is used not so frequently, and there is no information of the prevalence of this method of investigation comprehensive with the amniotic fluid index or single deepest pocket volume. So we talked about measurement. Measurement is of great importance because next part of our lecture will show us what are problems connected with abnormal range or volume of amniotic fluid. First is polyhydramnios. Sometimes the term hydramnios is used for the same situation. Polyhydramnios is a term used to describe an excess accumulation of amniotic fluid. This clinical condition is associated with high risk of poor pregnancy outcomes. The reported prevalence of polyhydramnios ranges from 0.2 to 1.6% of all pregnancies. Classification of polyhydramnios It is still useful. It may be chronic polyhydramnios characterized by a gradual accumulation of amniotic fluid throughout some period of time. It may be throughout pregnancy. An acute polyhydramnios characterized by sudden and rapid accumulation of amniotic fluid leading to more severe complications. Pathogenesis. Pay attention to the picture which is presented here and try to understand. The amniotic fluid volume reflects the balance between fluid production and movement of fluid out of the amniotic sac. In late gestation, the primary source of fetal urination and secretion of lung fluid, as we already told, and the main source of amniotic fluid removal of fetal swallow and absorption via the intramembranous pathway. What is the etiology of polyhydramnios? Around 50% of the cases are idiopathic, with experts still trying to find out the responsible causes. An underlying disease is only found in 17% of cases in mild polyhydramnios. In contrast, an underlying disease is detected in 91% of cases in moderate to severe hydramnios. The literature lists the following potential etiologies. Group of etiological factors: fetal causes, placental causes, and maternal causes. And in this picture, you can see some of these diseases which are leading to appearance development of polyhydramnios. You can see 72% of polyhydramnios are recognized as idiopathic. We still have no possibility to understand what is the reason in this case. As about fetal cases. First of all, fetal abnormalities. Fetal anomalies such as hydrocephalus, anencephaly, esophageal atresia, fetal kidneys problem, duodenal atresia, tracheoesophageal fistula, skeletal dysplasias, spina bifida, and diaphragmatic hernia that can hamper the baby's ability of swallowing and processing the amniotic fluid properly. Fetal anemia, RBC deficiency in the baby, hydrops fetalis, fluid accumulation or edema in two or more fetal compartments. Chromosomal abnormalities, inheriting abnormal chromosome responsible for genetic disorders like Down syndrome and Edwards syndrome, and they are very frequently connected or combined with polyhydramnios. Fetal macrosomia having a baby too large for gestational age. They are fetal causes. As about placenta causes, twin-to-twin transfusion syndrome, an abnormal condition occurring when carrying identical twins, in which one twin receives excessive amount of amniotic fluid while another has little. Placental blood vessel abnormality, abnormal fluid vessel growth, a growth on the placenta, for example, chorioangioma. In maternal cases, infectious conditions, pay attention please, toxoplasmosis, parvovirus, herpes simplex, rubella, cytomegalovirus infection, which are known as torch complex, or perinatal infections. Affecting the mother may also reach the fetus, causing various abnormalities. Maternal diabetes mellitus, gestational or pre-existing, one of the most frequent reasons of the development of polyhydramniosis. And in some cases, polyhydramniosis diagnosed in patient may be the first symptom which is pushing us to exclude diabetes mellitus. When we try to make it, we understand patient is suffering from diabetes. Rhesus disease, rhesus incompatibility. Mother is rhesus negative, fetus is rhesus positive. Rhesus incompatibility causes the mother's antibodies to cross the placenta to replace, to make a complex antigen agglutinin on the superficial area of the RBC, red blood cells, and leading to lysis, and because of these lysis, fetal anemia, hemolytic anemia of a fetus and newborn is developing. It is one of the principal causes of polyhydramnios. blood incompatibility between the mother and the happy, not dependent on rhesus factor but dependent on number of other components of blood, A, B, O, and so on and so on. Hypertension, maternal, pre-existing hypertension, and preeclampsia. Incidence of polyhydramnios. The degree of polyhydramnios can be considered as mild, moderate, and severe. And here is presented the incidence. 66% of all patients with polyhydramnios are suffering from mild, 22% from moderate, and severe is 12% of range. The most common causes of severe polyhydramnios is a fetal anomaly, often associated with underlying genetic disorders. 20 to 10% causes will have aneuploidy. Milder cases are associated with maternal diabetes, multiple gestation, and idiopathic factors. In the absence of a maternal fetal of the central cause, polyhydramnios is considered as an unexplained or idiopathic. The 95th centile and above for gestation is defined as polyhydramnios as it is shown in this picture. In pregnancy affected by polyhydramnios, approximately 20% of neonates are born with a congenital abnormality of some type, problems with the gastrointestinal system, 40%, central nervous system problems, 26%, cardiovascular system, 22%, genitourinary system, 13%. Therefore, the delivery of this newborn in a tertiary case setting is preferred. It means that if you find a patient with polyhydramnios, it had to be hospitalized into the tertiary hospital. How to make diagnosis? As usually, we use routine method of diagnosis questionnaire, paying attention to appearance or to presence of congenital anomalies of a child in previous pregnancy, presence of polyhydramnios in previous pregnancy, diabetes mellitus before pregnancy or during the first pregnancy that disappeared, obesity, infections in previous pregnancy, inspection, abdominal palpation. These two methods are done at any visit for any patient. Thus, you have to be only attentive and you will suspect that patient has polyhydramnios. Abdominal palpation will show some specific symptoms. What can we find in abdominal palpation? First of all, the shape of abdomen is not wide, the shape of abdomen is round. Some authors use the term frog's-like shape because fluid collecting in lateral spaces of abdomen, that's lie abdomen presenting when patient is lying in a dorsal position, looking like a frog's abdomen. Making palpation and percussion, you will pay attention to the wave-like movement of the abdominal wall, which means that it is polyhydramnios. It is a situation which can compare with the presence of ascites. Imagine studies and laboratory tests are used to final confirmation of these diagnoses. Here are presented clinical symptoms. Mild cases of polyhydramnios may not cause any noticeable signs in the mother. Severe cases, moderate cases can lead to the following symptoms: difficulty breathing unless standing or sitting on an upright position, difficulty clumping stairs, decreased urine production, larger belly size for one's gestational age, swelling of the abdominal wall, vulva and legs, excessive weight gain, as I'm already told, frogs-like abdomen and wave-like symptom in percussion, which is happening in percussion. Here is presented patient with the polyhydramnios, excessively large abdomen, which is looking as overextended with excessive stretch marks and excessive, sometimes you may find varicosis of the veins on the abdominal wall. So, besides Polyhydramnios may be suspected by the doctor in case of it seems difficult to assess the body contents and heartbeat of the fetus despite an enlarged size of the uterus. Patient has no obesity, patient feels movement, but auscultation is failure. Excessive amount of amniotic fluid in the uterus tend to worsen certain pregnancy symptoms such as indigestions, constipation, abdominal pain, heartburn, stretch marks. Varicose vein, when the walls within the vein stop working, causing the venous walls to become weak, leading to blood accumulation in the weak spots. So these are symptoms which will help you to diagnose polyhydramnios even if you have no additional apparatus. But if you have, it would be done earlier and more easy. So what are imagined studies? Diagnosis of polyhydramnios is based upon ultrasound assessment of the amniotic fluid volume, and in the first part of our lecture we told about three methods of calculating of amniotic fluid volume. This can be done using the single deepest pocket amniotic fluid volume. Also may be done with the help of the amniotic fluid index calculation. Systematic review of the patient having risk factors for development of polyhydramnios will help you to make diagnosis as early as possible. Early diagnosis, more successful treatment. And pay attention to this table, please. Here is presented the reference ranges for the degrees of polyhydramnios. With the help of single pocket measurement and with the help of amniotic fluid index measurement. Normal 2 to 7.8, amniotic fluid index 8 to 25.9, and so on and so on. Because I have now enough time, I propose to say this table, and even depending on the term age, gestation age, you may make primary decision about presence of polyhydramnios in the patient. It's about laboratory tests. Laboratory tests helping to identify causes of polyhydramnios include glucose tolerance test to exclude gestational diabetes, magnetic diagnostic testing for infection, maternal diagnostic testing for infection, torch serology. If there is suspicion of fetal anemia or fetal hydrops, test to exclude immunological causes, maternal blood group, rhesus factor screening for antibodies, hematological disorders, possibly clean Bedke test to exclude fetal maternal hemorrhage are indicated. So the literature also lists certain drugs, lithium, which are associated with a higher incidence of polyhydramnios. Lithium is a psychotropic drug prescribed prenatally to treat bipolar disorders. Fetal karyotyping for trisomy 21, 13, and 18 is indicated to make diagnosis of polyhydramnios, and intrauterine infection may be suspected based on maternal symptoms of fetal abnormalities such as hydrocephalus due to toxoplasmosis. Clinical significance. Many idiopathic cases resolve spontaneously, but polyhydramnios, as usual, has been associated with an increased incidence of many adverse outcomes. These are maternal respiratory compromise, preterm labor, preterm rupture of membranes, and preterm delivery. Would you like to imagine excessive volume of amniotic fluid, overextension of membranes, preterm premature rupture of membranes, followed with expulsion of number of fluids, and together with the fluids, umbilical cord would be delivered through vagina outside. Only 5 minutes we have to save fetal life in this case. It is very severe situation. Maternal fetal malposition in the uterus because of overextended uterus, widened cavity of the uterus and amniotic fluid. Fetus movements are more free movements, comprehensive with normal volume of amniotic fluid, and it is fluid with malposition, transverse lie, longitude, oblique line, or bridge presentation, cord prolapse, as I'm already told, uterine abruption, especially after rupture of membrane, longer second stage of labor, postpartum uterine atony. It is logical because it was overextended throughout a number of months. Low Apgar score at 5 minutes, transient tachypnea of newborn, jaundice, hyperglycemia, admission to neonatal unit, perinatal mortality, especially close to term. As about prognosis, the prognosis varies depending upon the underlying disease and severity of the polyhydramnios. In a normal singleton pregnancy, amniotic fluid volume increases progressively until 33 weeks gestation plateau from 33 to 38 weeks and then followed by a decline from 38 weeks onwards. Mild polyhydramnios frequently spontaneously resolves and is not usually associated with the best perinatal outcomes. Small for gestational age babies with polyhydramnios generally have the poorest prognosis. Overall, perinatal mortality in pregnancies with polyhydramnios is increased 2 to 5-fold compared to pregnancy without. Care should be individualized, but consider elective delivery at term in view of the possible increased risk of late-term fetal death in utero. As about obstetric complications, which are typical of patients with polyhydramnios, they are presented in this slide. Besides on complications which are directly dependent on the causative factor, we have special obstetric complications. What are these? Abdominal discomfort, uterine irritability, preterm labor, premature rupture membrane, fetal malposition, umbilical cord prolapse, placental abruption, postpartum hemorrhage, and neonatal complications. Higher rate of admission to neonatal special care baby unit, higher risk of tachypnea, higher birth weight, higher rate of congenital malformation neurological disorders, higher rate of cesarean section for fetal indications. And management, what to do if we made diagnosis of polyhydramnios. The first step is to identify if there is an underlying cause. Mild chronic polyhydramnios can be simply monitored and treated conservatively. Preterm labor is common due to overdistension of the uterus, and measures should be taken to minimize this complication. This includes regular antenatal check and inspection of the uterus and bed rest towards the late-term status. Intramuscular steroids should be given to the mother antenatally if preterm delivery is considered. This helps to improve lung maturity. Serial ultrasound scans should be carried out to monitor amniotic fluid index and monitor fetal growth. Fetal hydroxynemia should be treated with erythrocyte transfusion either intravascularly or via the fetal abdomen. This reduces the likelihood of fetal congestive failure, thereby allowing prolongation of the pregnancy and improving survival. Congenital infection may be associated with maternal signs or symptoms of infection and or fetal abnormalities. In the absence of maternal signs and symptoms of fetal findings, other than polyhydramnios, congenital infections such as rubella, cytomegalovirus, toxoplasmosis, syphilis is an unlikely cause of isolated polyhydramnios. Sonographic surveillance every 2 to 4 weeks is generally recommended in mild polyhydramnios that can be amended to every 2 weeks in moderate to severe cases until 37 weeks and then weekly. The surveillance can stop if the polyhydramnios resolves. In the methazine, Indomethacin is the drug of choice for the medical treatment of polyhydramnios. It is very effective, particularly in cases where the condition is related to increasing fetal urine production. The mechanism of action appears to be an effective on urine production by the fetal kidney, possibly to enhancing the effect of vasopressin. It is not effective in cases where the underlying cause of is a neuromuscular disease affecting fetal swelling or hydrocephalus. It is contraindicated in twin-to-twin transfusion syndrome or after 35 weeks, as adverse effects outweigh benefits in these cases. Amniocentesis is recommended in cases where indomethacin is contraindicated in severe polyhydramnios or in patients who are asymptomatic. It is contraindicated in premature rupture of or detachment of the placenta, or chorion amnionitis, inflammation of the chorion amniotic membranes and fluid. Inflammation is typical contraindication to any surgical intervention, even puncture of amniotic membrane and suction of fluid, which means amniocentesis. Induction of labor should be considered of fetal distress development. Beyond 35 weeks, it may be safer to deliver anyway. Induction by artificial rupture of the membranes should be controlled, performed by an obstetrician, and with consent to proceed to lower segment cesarean section if required. Polyhydramnios associated with twin-to-twin transfusion syndrome may benefit from these ablation to the connective placental vessels. Here is presented how it is done. Amnio reduction, amniocentesis with suction, fusion of some portion of amniotic fluid. Amnio reduction should be offered only in severe symptomatic cases associated with significant maternal discomfort or preterm labor before 34 weeks of gestation. Two methods are available: amnio reduction or decompression amniocentesis, prostaglandin synthetase inhibitors, mainly indomethacin. These drugs may stimulate fetal secretion of arginine, vasopressin, and facilitate vasopressin-induced renal antidiuretic responses and reduces renal blood flow, thereby reducing fetal renal flow. They also may impair production of or enhance reabsorption of lung liquid. It cannot be used, as we already told, in twin-to-twin transfusion syndrome or about 32 weeks, as the risk are the weighting of benefits. Main risk is fetal ductus arteriosus constriction, with this increasing with gestation. Schematically, I am repeating again, it is shown how it is done with special tools. Puncture of amniotic fluid under sonographic control to avoid puncture of any fetal parts and umbilical cord, and taking out of some milliliters of amniotic fluid. As about complications of polyhydramnios, it seemed to me that we already told there is a high incidence of preterm labor and delivery. Other maternal complications include premature rupture of membranes, abruption of placenta, malpresentation, postpartum hemorrhage, cord prolapse. It is higher incidence of cesarean section in categories of patients with moderate and severe polyhydramnios. A study of pregnancies associated with polyhydramnios but not congenital malformation showed that polyhydramnios was an independent risk factor for low birth weight, low Apgar score, and fetal death. Polyhydramnios prognosis. Only 16.5% of pregnancy with mild polyhydramnios have a significant associated problems. Poor prognosis is associated with fetal or placental malformation. The perinatal mortality rate in such cases is 1%. 20% of infants in polyhydramnios pregnancies have an abnormality, different types of abnormalities. The severity of the prognosis is dependent on the severity of these abnormalities. The more severe the polyhydramnios, the more likely the chance of finding an underlying cause. Now, oligohydramnios, opposite situation. Oligohydramnios refers to amniotic fluid which volume is less than expected for gestational age. Example, amniotic fluid index less than 5 centimeters. The incidence rate depends on variations in diagnostic criteria, the population studied, low or high risk screening or indicated ultrasound examination. The threshold used and ranges about 11%. Perinatal mortality increasing 30-fold when the single deepest volume packet was less than 2 centimeters, when the single deepest pocket was less than 1 centimeter, perinatal mortality increasing 47-fold. What is etiology of oligohydramnios? Fetal factors, fetal urinary tract abnormalities such as renal agenesis, polycystic kidneys, or any urinary obstructive lesions, posterior urethral valves, for example. Preterm rupture of membranes and chronic leakage of the amniotic fluid. Chorioamnionitis is an additional important maternal complication from oligohydramnios due to rupture of membranes, which has an incidence of 21 to 74%. The earlier chorioamnionitis occurs in pregnancy, the greater the fetal risk of bronchopulmonary dysplasia, neurologic complications, pulmonary hyperplasia, and in severe cases, respiratory failure in neonates. As about maternal factors, placental insufficiency as seen in pregnancy-induced hypertension, maternal diabetes, or post-maturity syndrome, while the pregnancy extends beyond 42 weeks gestation. Maternal use of prostaglandin synthetase inhibitors or other inhibitors. Symptoms. It may or may not cause undetectable signs in the affected woman. In case of ruptured amniotic sac, one may notice a constant feeling of wetness due to vaginal fluid leakage. The uterus may also look smaller than it should be at this gestational age. What are complications? Oligohydramnios occurring during the first and the second trimester is more likely to cause serious complications than when it occurs during the third trimester. Birth defects, malformation or complete absence of some external or internal organs in the newborn, hip dysplasia, clubfoot, premature birth, delivery before completing 37th week of pregnancy, miscarriage, death of the baby in the uterus before 20 weeks of pregnancy. It is rather frequent situation, by the way. Stillbirth, death of the baby in the uterus after 20 weeks of pregnancy. It is also possible. And death of a newborn shortly after birth. Thus, it is very risky for a baby at any gestational age. Oligohydramnios can lead to the following problem when occurring during the third trimester. Fetal growth restriction, an umbilical cord compression during labor, delivery, and of course, such complications need in abdominal delivery means cesarean section. Diagnostics. Imagine studies, single deepest pocket measurement, amniotic fluid index, as we already told, test for systemic lupus erythematosus, which causes immune-mediated infarcts of the placenta and placental insufficiency, leading to development of oligohydramnios. Evaluate for elevated blood pressure and hemolysis, elevated liver enzymes, and low platelet count syndrome. Test for proteinuria, elevated uric acid, increased liver function test results in low platelet count. Speckle exam. It helps to detect any rupture of membranes responsible for oligohydramnios. As about medical care, treatment, management, consider hospitalization and thoroughly evaluation of the mother in cases when oligohydramnios diagnosed after 26 to 33 weeks gestation. If the fetus doesn't have an anomaly, delivery should be performed if the biophysical profile is non-reassuring. The installation of isotonic solution chloride in the second trimester may be of benefit in some patients. Use transabdominal amnio infusion to instill 4 to 600 milliliter, which may improve visualization for ultrasonography and increase volume of the amniotic fluid. Study shows the oral hydration by having the woman drink 2 liters of water, increasing the amniotic fluid index by 30%. But of course, it can be done if mother is not suffering from any kidney disease. In singleton pregnancy, where oligohydramnios is present without maternal fetal complications, evidence exists that either oral or intravenous maternal hydration up to 1.5 to 2.5 thousands milliliter daily is associated with a 20-30% improvement of amniotic fluid index and reduction on cesarean delivery. Rapid delivery may be indicated in cases when fetus is not markedly compromised yet. And now, the second part of our lecture is multiple gestation. Multifetal gestation, multiple gestation, multifetal pregnancy. Multiple gestation occurs when multiple fetuses are carried during a pregnancy with subsequent delivery of multiple neonates. Pregnancies complicated by multiple births are associated with a higher rate of neonatal morbidity and mortality, paralleling the increased risk of preterm labor, low birth weight, and other associated high-risk morbidities. Maternal morbidity and mortality are also increased in pregnancies complicated by multiple gestation and multiple birth. Names for multiple pregnancy include the following: twins, 2 fetuses; triplets, 3 fetuses; quadruplets, 4 fetuses; quintuplets, 5 fetuses; sextuplets, 6 fetuses; septuplets, 7 fetuses, and more. Multiple gestation incidence. The incidence of multiple gestation increasing significantly in the late 20th century worldwide. A combination of factors contribute to this, the two most prominent of these being the use of artificial reproductive techniques and advanced maternal age at the time of conception. Twins are more common type of multiple pregnancy, and it's appear more frequently within the last century, as we already told. So now we have to understand what are types of multiple gestation. Multiple birth siblings usually distinguished as monozygotic, dizygotic, polyzygotic, and litter. Monozygotic pregnancies. Monozygotic pregnancies involve the fertilization of a single ovum by a single sperm. Monozygotic twins develop when a single fertilized ovum splits after conception into 2 or more embryos, each carrying the same genetic material. Not monozygotic twins, but monozygotic pregnancy develop when a single fertilized ovum splits after conception into 2 or more embryos, each carrying the same genetic material. Siblings created from one egg are necessarily the same sex, except in very rare cases, and are commonly called identical. Genesis of monozygotic twins. Embryo splits at day 3, 2 chorions, 2 amnions. Embryo splits at 4 to 7 days, single placenta, 1 chorion, 2 amnion. Embryo splits at 8 to 12 days, single placenta, 1 chorion and 1 amnion. Rare. Embryo splits after 13 and after 13 days, conjoined or Siamese twins, very rare situation. So splitting occurs within 3 days after fertilization. We have 2 embryos, we have 2 amnion, we have 2 hormones develop, and it is known as monozygotic, diamniotic, dichorionic twins pregnancy. DDD, diamniotic, DD, dichorionic, diamniotic, monozygotic. Embryo splits in 4 to 7 days. Monozygotic, diamniotic, monochorionic twins pregnancy. 1 placenta, but 2 cavities, 2 umbilical cords. Monochorionic, diamniotic. Here, 2 embryo, monozygotic, diamniotic, dichorionic, diamniotic, dichorionic, monochorionic, diamniotic. Embryo splits at 8 to 12 days, monochorionic, monoamniotic. Placentation is observed. The twin fetuses are contained with the same amniotic cavity, have single common for both placenta, but every fetus has its own umbilical cord. MOMO, monochorionic, monoamniotic. The most severe situation for practice. In monochorionic twin pregnancies, one twin can receive a reduced blood supply and have a slower growth rate, twin-to-twin transfusion syndrome. Sometimes one's fetus dies and form a mummified fetus, but perishes or reabsorbed. Twin-to-twin transfusion syndrome, also known as fetal-fetal transfusion syndrome, and twin oligohydramnios polyhydramnios sequences, is a complication of disproportionate blood supply resulting in high morbidity and mortality. As a result of sharing a single placenta, the blood supplies of monochorionic twin fetuses can become connected so that they have blood circulation, that they share blood circulation. Although each fetus uses its own portion of the placenta, the connecting blood vessels within the placenta allow blood to pass from one fetus to another. Depending on the number, type, and detection of the interconnecting blood vessels, anastomosis, blood can be transferred disproportionately from one twin, which is donor, to the other, which is recipient. And in this picture, it is shown comprehensive size and condition of donor and recipient. This state of transfusion causes the donor twin to have decreased blood volume, retarding the donor's development and growth, and also decreases urinary output, leading to a lower than normal level of amniotic fluid, becoming oligohydramnios. The blood volume of the recipient, which is increased, which can strain the fetus heart and eventually lead to heart failure, and also higher than normal urinary output, which can lead to excess amniotic fluid, becoming polyhydramnios. We will come back again to twin-to-twin transfusion syndrome treatment, but now let me continue classification and types. Dizygotic, 66% of twins. Dizygotic of fraternal multiples occur when more than one egg is fertilized and implants in the uterus. It can produce boys, girls, or combination of both. Fraternal multiples are simply siblings conceived at the same time. Fraternal multiple each have a separate placenta and its own amniotic sac. Here is presented dizygotic fertilization of 2 separate ova. They are having development and growing in the only uterus and dependent on each other simultaneously. In dizygotic multiple pregnancies, each fetus has own placenta. Sometimes it may be fused, but most of cases it is it is separated. So, any fetus has its own placenta, amnion, and chorion. Dizygotic twins pregnancy is a dichorionic, diamniotic pregnancy. Dizygotic twins pregnancy is shown here. D chorionic, D amniotic. Fetal chorionic, D amniotic placenta. In the twin zygotes implant close together to the uterine wall, the placenta disc may show varying degrees of fusion, and sometimes it may looking as the single placenta for two twins, but histological, biochemical, and genetic examination will show exactly what is the origin. So here is presented, maybe it is known for everybody, how it is develops identical monozygotic twins. Fertilized ovum is the only, but it is divided into two cells and two fetuses, for example, has further development. And fraternal dizygotic twins, two fertilized ovum, two ovum fertilized simultaneously at the same time, parallel, fertilized, and we have two fetuses in the only uterus with its own placenta and its own amniotic cavity. As about polyzygotic multiples, multiples called represent some combination of fraternal and identical siblings. For example, a set of triplets may be composed of identical twins from one egg and a third sibling from a second egg. Etiology of multiple gestation. Heredity. First etiological factor. Family history of multiple gestation pregnancy increases the chances of having twins. Old age. Women over 30 have a greater chance of multiple conception. Many women today are delaying childbirth until later in life and may have twins as a result. High parity. Having one or more previous pregnancy, especially multiple pregnancies, increases the chances of having multiple. Race. African American women are more likely to have twins than any other race. Asian and Native Americans have the lowest twinning rates. Caucasian women, especially those over age 35, have the highest rate of higher order multiple birth, triplets or more. Reproductive technology. Now they become one of the most frequent reasonable factor. Ovulation stimulating medication such as clomiphene citrate, follicle stimulating hormone help produce many eggs which, if fertilized, can result in multiple gestation. In vitro fertilization and other techniques help couples conceive. These technologies use ovulation stimulating medication to produce multiple eggs which are then fertilized. Differential diagnosis multiple gestation. Early, misdated pregnancy, polyhydramnios, uterine fibroids tumors, cyst and heredity from more. When we have suspicion. So first of all, what should push us to suspect that it is multiple gestation? Non-correspondence of the uterine size to the calculated or expectant gestational age. Thus, what are problems? Maybe misdated pregnancy, maybe polyhydramnios, maybe uterine fibroid tumor, and not only fibroid, by the way, tumor, cyst, and heredity from more. Diagnosis of multifetal gestation. First, history. Maternal family history of twins, advanced maternal age, high parity, large maternal size, and a personal history of twins provide weak clues to the diagnosis of multifetal gestation. Fraternal family history of twins have the same role in diagnosing and developing, by the way, have the same chance to get multifetal gestation. Next is clinical examination. First of all, we are paying attention to the uterus size or symphysis height in women with a uterus that appears larger for gestational age. The following possibilities are considered. First, multiple fetuses, elevation of the uterus by a distended bladder. That's why when we are trying to make any external or internal obstetrical exam, we are asking our patient to empty bladder. Inaccurate menstrual history, hydramnios, hereditary malnutrition, uterine myoma behind benign tumor of the uterus. It wasn't verified before pregnancy, but that lead to becoming uterus larger for gestational age during the pregnancy and may be verified firstly during the pregnancy. A closely attached adnexal mass lead to the same problem, and fetal macrosomia late in pregnancy. In this case, we have to pay attention what is the father or partner's size. Maybe he is very tall, large person, or we had to exclude diabetes mellitus. As about clinical examination, palpation of the fetal parts. When uterine palpation leads to the diagnosis of twins, it is most often because two fetal heads have been detected, often in different uterine patterns. With one of my group, when we made curation of patient, one or two students got patient for making case record. I was staying near them and observing how they made Leopold maneuvers. And they were so surprised and happy when they understood that one head is palpated at the area of the fundus, and then they found the second head in the lower part of the uterus with the third Leopold maneuver. And firstly, they discussed it in between themselves, and I understood that they are making it their own language, but I understood that they are suspecting twins pregnancy. They didn't believe the sermon as me, so it's like, ma'am, is it twins? Of course it was twins pregnancy. So palpation of the fetal parts. 2 or 3 large parts of the fetus. Fetal heart evaluation. Doppler ultrasound equipment. Auscultation of the fetal heart sounds with even stethoscope and cardiotographic exam exactly. Biochemical test is about routine auscultation of the fetal heart sounds with a penis stethoscope or other type of stethoscope. We had to differentiate first of all fetal heart sounds from maternal heartbeats. Place your hands on maternal wrist. Find a place where there is most audible fetal heart sounds and calculate within 15 seconds or better within 1 minute. The rate 140, 150, it is fetal. 70, 80 in maternal wrist will help you to differentiate. But if you're palpating on the 2 types of abdomen, 140 beats per minute, absolutely other please, 180, 160, it means that it is another fetus. With a spinal stethoscope, you're already able to make diagnosis of multifetal pregnancy. Biochemical test will help us to understand that it is twins or triplets or more multifetal pregnancy using HCG test, human chorionic gonadotropin. The amount of chorionic gonadotropin in plasma and in urine on average are higher than those found with a singleton pregnancy, but not so high as to allow a definitive diagnosis of multiple fetuses. Twins are frequently diagnosed during an evaluation for an elevated maternal serum alpha-fetoprotein level. But HCG would be higher and alpha-fetoprotein level. Alpha-fetoprotein levels of a protein released by a fetus liver and found in the mother's blood may be high when more than one fetus is making the protein. Currently, there is no biochemical test that reliably differentiates between the presence of one or more than one fetus. And to get out fetal protein, we had to make puncture of amniotic fluid itself. Amniocentesis has special indications and contraindications, and itself amniocentesis has some significant side effects. Complications as rupture of amniotic fluid, expulsion of amniotic fluid, starting of preterm uterine contractions, preterm labor, miscarriage, and so on and so on. Imagine studies, ultrasonography, both transabdominal sonographic exam and transvaginal sonographic exam. Here are presented three pictures showing gestational sacs in the uterus. In another picture, sextuplets. And in 3D dimensions ultrasound, there are visible two fetuses in the uterine cavity. Other studies, fetal echocardiography, fetal MRI, chest radiography is used to evaluate respiratory distress. Multiple gestation. What is the clinical cause of pregnancy? What are problems for us, obstetricians, if we have a patient with multiple gestation? Of all the types of multiple birth, twins normally face the fewest medical problems and complications. Each additional baby a woman carries during her pregnancy increases the possibility of developing pregnancy complications. The risk of complication in pregnancy and labor increases in 2 to 3 and more folds. What about maternal complications? Antepartum, hyperemesis gravidarum, hydramnios, preeclampsia syndrome, precious symptom with pains and failure of just norms, anemia due to increased demand, but with not single fetus but number of fetuses which are developing inside, antepartum hemorrhage, postpartum hemorrhage. As about intrapartum, dysfunctional labor, overextended uterus may present weak labor pains, may present uncoordinated labor pains, malpresentations, followed with increased risk of fetal traumatism, with increased risk of cesarean section, operative delivery, postpartum hemorrhage, retained placental part, followed with lack of uterine contractions, development of local metra, subinvolution of the uterus, endometritis, and so on and so on. Premature separation of the placenta, which presenting bleeding intrapartum and leading to the suffering of the fetus. Fetuses may even die because of separation of the placenta, and maternal risk is so high term. Fetal complications, malpresentations, placenta previa, abruption of placenta, premature rupture of membranes, prematurity, umbilical cord prolapse, umbilical cord compression, development of true real knot of the umbilical cord, which is followed with appearance of asphyxia of the fetus inside the uterus. Intrauterine growth restriction, congenital abnormalities, low birth weight, you know it, and twin-to-twin transfusion syndrome. The highest risk is monochorionic monoamniotic pregnancies. Inherent risk of other conditions. Preterm labor, intrauterine growth retardation, hypertensive diseases is also found in multiple fetus pregnancy, and the risk of this situation is higher in this type when it is monoamniotic twins, and it is presented through knot of the umbilical cord compression, which is followed with the resting of blood flow. And as I told you, few words about twin-to-twin transfusion syndrome. We already understand what does it mean. One baby is donor, another is recipient, and both are suffering because For both of them, it is leading to failure for donor, to failure of the kidneys function, dysfunction, and for the fetus who is recipient, overloading with the volume of blood circulating in his organism will lead to failure of the heart functioning. So, Diagnosis of twin-to-twin transfusion syndrome. Doctor may suspect twin-to-twin transfusion syndrome based on the result of routine prenatal ultrasound. Maternal fetal medicine specialists can confirm the diagnosis by conducting more detailed testing to measure amniotic fluid volume, bladder filling, and blood flow in the recipient and donor twins. In complicated cases, in cases of twin-to-twin transfusion syndrome, minimally invasive surgery can offer the best chance of having two healthy babies. And within the last 50 years, it is already started to be not so rare surgical intervention. This surgery, known as endoscopic laser ablation, is performed in uterus and can correct the blood sharing imbalance caused by twin-to-twin transfusion syndrome. This laser used to separate anastomosis. In the first left picture, which is upper, slightly upper, it is seen round circle surrounding arteria anastomosis. Greenish surrounding vein-to-vein anastomosis. Different types of anastomosis. Quadrant, dark in color, shows arteriovenosis anastomosis, and red oval showing the area of multiple venous arterial anastomosis. So, first of all, we had to have special tools to find out these anastomoses. Then, with the help of endoscopic laser ablation, we had to separate it or eliminate it. And in this case, the next picture showing the results. A normal Katsaledon with paired vessels from and to the same fetus. B showed Katsaledon with artery and vein belonging to a different fetus. And C superficial unpaired vessels that do not connect it closely. So we may have three varieties of results, and all of these varieties help to have to the mother two healthy babies. The cause of pregnancy and multifetal gestation. As part of obstetrical complications, they are presented here. Preeclampsia. Comprehensive with singleton pregnancy, it is increases 3 to 4 folders, and most of them are of moderate and severe degree. Maternal anemia, it is understandable. Hemorrhages in labor, it is understandable because it is overextension of the uterus, because it is premature separation of the placenta. Even rupture of the uterus may take place. Hydramnios, we already told about it. Maternal renal failure, lung dysfunction, and etc. These are complications complicating the course of pregnancy. What about the management? Multiple gestations, including twins, triplets or more, are high-risk pregnancies, and they account for a disproportionate share of both maternal and fetal complications and adverse pregnancy outcomes. The risk for women with multifetal pregnancy include preterm labor, premature rupture of membranes, gestational hypertension or preeclampsia, gestational diabetes, anemia, and thromboembolism. Delivery of more than one baby is also more complicated, with a greater risk of cesarean section and postpartum hemorrhage. Because of the high rate of preterm delivery in multiple gestation, these babies are at greater risk for adverse neurologic outcomes, such as cerebral palsy, compared with a singleton pregnancy. Additionally, fetuses in multiple gestation have a greater risk of chromosomal and structural abnormalities. Management of multiple pregnancy may include the following. Increased nutrition. Mother carrying 2 or more fetuses need more calories, proteins, and other nutrients, including iron. Higher weight gain is also recommended for multiple pregnancy, and from the very beginning of pregnancy, iron supplementation is indicated for this patient. More frequent prenatal visits. Multiple pregnancy increases the risk for complications. More frequent visits may help find complications earlier and not for effective treatment or management. The mother's nutritional status and weight should also be monitored more closely. Thus, we propose to patients to come at the first trimester of pregnancy once 2 weeks. At the third trimester of pregnancy, better to come to the visit every week. Referrals. Referral to maternal fetal medicine specialist called the perinatologist for special testing of ultrasound evaluation and to coordinate care of complication may be necessary. Increased rest. Some women may also need bed rest. This can take place either at home or in the hospital depending on pregnancy complication or in the number of fetuses. Maternal and fetal testing. Testing may be needed to monitor the health of the fetus, especially if there are pregnancy complications. Tocolytic medicines. Tocolytic medicines may be given if preterm labor happens or there is threatening of preterm labor to help slow it or stop contractions of the uterus. These may be given orally. These may be given intravenously. Drop-by-drops tocolytic medicines often used include magnesium sulfate. There are special indications for different types of tocolytic medicines, and it would be topic for separate lecture. And corticosteroid medicines. Corticosteroid medicines may be given to help mature the lungs of the fetuses. Lung immaturity is a major problem of premature babies and in multiple gestation not only for premature babies. Multifetal reduction. Given the risk that multiple gestation confers, some women elect for fetal reduction, especially in the setting of higher order multiples. This is typically performed by potassium chloride injection into the selected fetus. However, if a selective reduction is contemplated in a multiple pregnancy with a vascular anastomosis, I cannot use potassium and occlusion of the selected umbilical cord, usually by a photocoagulation, can be done. And now, at last, mode of delivery. We managed patient from the very beginning up to the term of labor. Now we had to choose mode of delivery and time of delivery. The typical recommendation for the delivery of twin triplets and higher order multiples is cesarean, but twins are often delivered vaginally. Only twins may be delivered vaginally, but there are special indications for vaginal delivery of twins. Other triplets and more had to be delivered by cesarean section. I repeat again, twins may have special indication for cesarean delivery too. The vaginal delivery of twins depends on the presentation of the babies. Twins can be delivered vaginally when gestation is greater than 32 weeks. When twin A, the baby closest to the cervix, is the largest. Let it be vaginal delivery. Overextension of the soft tissue of the labor canal will give easy possibility for the second baby to be delivered. Twin A, the baby closest to the cervix, is head down, has cephalic presentation. It is more appropriate. Let it be. It may have delivery through maternal passage. Twin B is head down, bridge or sideways. May have delivery. twin B is smaller than twin A. There is no evidence of fetal distress, and there is no cephalopelvic disproportion. Fetus conditions are good. Pay attention please to this situation. The first baby, twins A, was presenting with bridge presentation. The second baby, twins B, had cephalic presentation. First baby started its passage through maternal passage. First baby already partially delivered, but together with the baby A, baby B, which is in cephalic presentation, stars is descending too. And what's happened? Extension of both hands lead to locked twins appearance and arresting of the process of labor. Thus, the situation when twin A is in bridge presentation, while twin B is in cephalic presentation, is absolute indication for caesarean section. It is easy to remember nowadays because any bridge presentation, especially in India, means indication for caesarean section. Thus, twins A is in bridge makes caesarean section. Twins A is in bridge, twins B is in bridge, makes caesarean section. Twins A bridge, twins A cephalic makes caesarean section. It is easy to remember this presentation. As about timing of delivery, the timing of delivery has not been well established in higher order multiples and therefore should be individualized. Prospective evidence regarding optimal timing of delivery for twins is also lacking. Should elective delivery be scheduled prior to 37th gestation, assessment of fetal lung maturity is recommended by American College of Obstetrician and Gynecologists. Monochorionic, monoamniotic twins are at increased risk for perinatal mortality, primary due to cord entanglement, and subsequently should have intensive fetal monitoring during the antepartum period. Delivery is usually recommended between 32 to 34 weeks gestation given the high rate of perinatal mortality. This is the end of our lecture. That's all I wanted to deliver to you today. Thank you for your attention. Best wishes for you and try to be healthy these difficult times. See you later. Bye bye.